Wow, you all can hear me. Welcome to this afternoon's session and to our four speakers who are with us today. We will go through each speaker and give some time for questions after each one, and then if we have time at the end, we can ask additional questions. So we will start with the first presentation. And I will introduce Rizka Maluda, who will come up and do her presentations on environmental correlates of adolescent active travel to school in Asia and ecological study. Thank you.
Greetings, everyone. My name is Rizka Maluda. I'm currently a PhD student at the University of Cambridge, based in the MRC Epidemiology Unit. I will be giving a presentation on one part of my PhD, which is the active environmental correlates of adolescent active travel to school in Asia and ecological study. Okay, so 80% of adolescents are insufficiently active, as defined by the international guidelines of physical, engaging in 60 minutes of moderate to vigorous physical activity. Okay. And their physical activity tends to decline as they grow older. And studies have reported that health benefits gained from physical activity in adolescents are carried forward into adulthood. Children and adolescents who actively travel to school are shown to be more likely to be physically active. And according to the ecological model of health behavior, factors at multiple levels can influence health behaviors, and past studies have shown that active travel to school is influenced by both individual and environmental level factors.
The link between urban development and family planning.
So the trends in Asia, many low and middle income countries, including those in Asia, experienced rapid urbanization that led to shift in daily travel patterns towards
I'm going to give an introduction
on
before
private
the film,
motorized
okay?
vehicle. And as many of these countries develop
panel session on family plan, on when family planning meets
income levels grew, motorized vehicle ownership
Africa.
increased, and which much
Addressing
of the infrastructure geared towards
challenges
new
for
roads,
urban health.
subways, and flyovers.
My name's
Thus,
Mary
making motorized vehicle
I'm the
more
executive director
desirable,
for the International
and there's an
Union
increase in
for the
reliance on
Scientific
private
Study
motorized
of
vehicle
Population,
across these countries.
the IUSSP.
With the increasing of use of private motorized vehicles, travel-related physical activity is decreasing and is expected to continue to decrease further from 2020 to 2030.
And evidence-based
Additionally, many Asian cities also dominate the top 20 of most severe air pollution
conference every 4 years.
This is where active travel promotion can help increase
of an
physical activity, reduce road traffic injuries, and decrease air pollution, especially in heavily populated
by
areas.
Trudy Harpham, who'll be speaking later, and John Cleland,
in our previous study, it was shown that
has guided a project
55% of Asian adolescents are actively traveling to school.
That was funded
we also
by
found that among these Asian adolescents, older and male adolescents were more likely to actively travel to school. However, the main contributors to country-level differences in adolescents
Africa to
active travel to school prevalence remains unknown.
On urban fertility and family planning.
Therefore, this study, the primary aim of this study was to examine the association between prevalence of adolescents active travel to school and country-level environmental correlates in Asia. And the secondary aim was to examine their association with country-level differences in active travel to school by age.
The research is now being wrapped up.
Now we're moving on to the methods. We use ecological study design with country-level variables, and these are the dependent. We have three dependent variables.
To bridge
the first dependent variable is the country-level prevalence of adolescent active travel to school, difference in prevalence of adolescent active travel to school by age group, difference in prevalence of adolescent active travel
and
by
the second
sex.
gap between
And
urban planning
these
and family
data
planning,
come
with
from
the
the global
objective of making urban planners
school-based
and
student
city
health
government
survey
officials more aware of the contributions of
developed
family
by the
planning to
WHO and
urban
CDC,
development and to
it is a school-based survey conducted mostly among students aged 13 to 17 years,
and to start
and it used a two-stage cluster sampling design to obtain a nationally representative sample of the adolescents and use standardized sampling and data collection methods.
The Afro Cities Conference. That'll give
In
you a
our
flavor
previous
of what
study, we
were trying to do.
generated prevalence of adolescents active travel to school, as shown in the previous map. And we use the prevalence from these 31 countries in this ecological.
Africa's future. What do you need to know, and what can you do? Most future population growth will take place in urban areas, and this is especially true for Sub-Saharan Africa. Such mounting urbanization presents challenges for the planning and provision of physical infrastructure and social services. Most of this urban population growth is due to natural increase. That is, a greater number of births than deaths within cities, and not rural to urban migration. Plus, while women living in African cities were having on average less and less children over time, recent research shows that this decrease is no longer happening in many places. For example, Harare, Accra, Lagos, Nairobi, Dar es Salaam, Kinshasa, and Niamey. People living in African cities want to be able to plan their families. City populations tend to be younger than in rural areas, and millions of urban women want to space or limit their births, and yet can't get adequate access to reproductive health services. This is called unmet need, and ranges from 1 in 10 in Zimbabwe to 4 in 10 in Angola. Recent research shows that about 1/3 of women in a low-income settlement in Kampala, Uganda, have unmet need. In Kenya, 3 in 10 women face unmet need in slum areas, more than double the level for urban women overall. Many young, unmarried people in cities face discrimination when trying to get modern methods of contraception. Responding to this need is a win-win. Family planning is an underappreciated way of promoting productive, sustainable, and equitable development in urban Africa. And there are yet more wins. Enabling couples to plan their families leads to better education for women, greater empowerment, reduced poverty, and better infant, child, and mother's health. But can we afford it? Family planning is a low-cost way to promote urban economic development, gender empowerment, and city resilience. The average direct cost of supplying a modern, effective contraceptive to a couple in Africa is about $8 a year. Less rapid expansion of cities makes it much easier for city officials to plan for long-term investments like infrastructure and waste removal. When cities grow very fast, it's difficult to provide these basic services, especially to the poor. Cities are seen as an engine of development as shown by the adoption of the standalone goal, SDG 11 on cities and communities, make cities inclusive, safe, resilient, and sustainable. Action to support urban family planning choices enables us to meet this goal and moves us towards the realization of the African Union's Agenda 2063, as long as we act now. There are great success stories in Africa where mayors have led the way in supporting family planning for positive urban development. For example, local governments in more than 70 cities across 9 countries in Africa have partnered with the Challenge Initiative to scale up high-impact interventions in family planning for the urban poor. These cities are reaping the benefits of improved access to family planning, and many more can enjoy the same gains. Sustainable urban development is possible if decision makers in Africa work with reproductive health experts to understand and meet a city's family planning needs. This information and action will help to provide quality services such as clean water, waste management, and overall infrastructure to all city residents. Follow the example of leading cities by joining inspiring initiatives and strategic partnerships. Your leadership can maximize the power of family planning for urban development.
Now I will turn this over to Dr. Eliphas Gitonga, who will be the moderator for the session and will introduce the speakers. Thank you.
Thank you very much, and it is a happy time and a happy moment in Valencia. We want to again continue with this panel that is discussing the meeting of family planning to urban development and focusing on Sub-Saharan Africa. I am one of the fellows that is funded by this project. My project is in Nairobi, Kenya. So we have a big privilege to get more insight into this direction. And I want to take this opportunity to welcome the first or the second presenter, who is James Duminy, who will be discussing the patterns and trends in fertility and family planning in urban Africa. He will be bringing the implications for urban development. Welcome, James.
Thanks, Eliphas, and good afternoon. So it's a privilege to once again be talking about some of this work that I've been involved in for the last 3 years or so. And in particular, I am going to be talking about, sorry, I'm having a little bit of problem changing the slides. Right, okay, you're going to change the slides. Oh, there's a clicker, right. Even better. Okay, so I am going to talk about the second of these 3 items, which was a state-of-the-art literature review that I did of work published on the links between urban development and fertility and family planning, focusing on low and middle income countries, but with a particular focus on Sub-Saharan Africa and South Asia. I worked with Professor Susan Parnell at the University of Bristol, and also with wonderful inputs from Trudy and other colleagues on the scientific panel. After this, Sue is going to talk a bit more about some work that she and I did, looking at where we interviewed urban sector specialists to try and better understand how we might be able to go about influencing the urban development agenda from a family planning perspective. So the first point that I would like to make then is that, broadly speaking, in Africa, urbanization does and will promote fertility decline. So this is something traditionally predicted by the demographic transition model, that having a greater proportion of people, of populations living in towns and cities, will tend over time to decrease the average fertility rates of those countries. That's for a range of reasons. I can't go into them in any great detail, but the increased costs of childbearing, of social reproduction, of housing, education, etc., and the fact that larger proportions of urban women tend to be involved in wage employment. But the situation that we see over the last 2 to 3 decades is something relatively unprecedented and not predicted by the demographic transition model. We see a situation where there have been the expected decreases in average fertility rates have stalled, or they've in fact reversed in urban areas. These urban fertility stalls, which were mentioned in the video that we've just shown, as I say, relatively unprecedented. They've been observed for around 50% of all capital cities in African countries. In fact, we've seen recent increases in urban fertility rates in very populous countries like Nigeria, the Democratic Republic of Congo, and Tanzania. And for other categories of urban areas, such stalls have been observed in around 1/3 of all countries. The situation is essentially quite different from what we see for a country like India, which follows very much the traditional notion of the demographic transition, where you see this gradual decline over time in urban fertility rates. What we see in East Africa, for example, looking at these 3 countries, Uganda, Tanzania, and Kenya, is a far more complex temporal pattern with periodic increases in urban fertility rates, but overall, a tendency towards the stabilization of urban fertility rates at levels that are sometimes quite well above the population replacement fertility rate of 2.1 children per woman. So in the case of Uganda, for example, relative stabilization in the upper threes towards 4, fertility rate of 4. If we look at 2 highly populous countries where in future years we will see enormous rates of urban population growth and urban spatial expansion, the tendency there in Nigeria has been towards stabilization, again, at relatively high levels, well above replacement level of 2.1. And in Ethiopia, quite interestingly, a marked uptick in urban fertility rates in the period between the most recent demographic and health surveys. Now, these fertility stalls or reversals haven't followed any kind of specific geographical distributions. They haven't been associated with either urban or rural areas to any consistent extent. In fact, if you look at Nigeria, you see that stalls and reversals have been both urban and rural phenomena, but that in the rural context, there's been a more pronounced effect in recent years. If we look at Ethiopia, we'll see that the fertility stall or reversal is in fact almost exclusively an urban phenomenon, and that rural fertility rates have continued to decline over time, in part reflecting, I think, that government's sustained interest in extending family planning services to rural populations. The research doesn't actually come up with any conclusive statements about what the specific factors are that are driving these fertility stalls and reversals. Scholars like Alex Eze and colleagues at the African Population and Health Research Center have pointed to the possibility that declining international and national government support for family planning programs from the 1990s, in particular following the landmark International Conference on Population and Development in Cairo, might have interrupted access to family planning services, and as a result leading to these knock-on effects for fertility stalls a few years later. Other scholars have said that this might be due to conditions of socioeconomic uncertainty, whereby higher levels, families are choosing to retain higher levels of desired fertility in part as a kind of social insurance mechanism against those conditions of uncertainty. And finally, scholars more recently, like Wolfgang Lutz, have argued that they might be potentially better explained by disruptions to the education of women and girls arising and following on from economic crises and structural adjustment programs of the 1980s and the 1990s. So there is a broad diversity of perspectives and explanations for what actually is happening to drive these urban fertility stalls and reversals. What we do know, however, is that if these stalls or reversals continue, it's going to mean sustained rapid rates of urban population growth. It's going to place pressure on housing stocks, potentially sustain high rates of urban poverty, and while at the same time ensuring pressure on urban health services and the health of the population through the life course. It also just raises more general fundamental questions about how cities should be planned and governed, about how we should invest money, where that money should be invested. It's going to be a major challenge to deal with in future years. Now, the second part of the presentation, I'm just going to talk about a bit about geographies and geographical distributions of unmet need for family planning. The video introduced this concept of unmet need. It's something that I've had to become much more familiar with than I thought I would when I started this research. Essentially, it's a measure of the proportion of women who would like to limit their childbearing, but for some reason aren't using contraception or family planning services for whatever reason, whether that be disruptions in supply or issues related to demand. Historically speaking, African governments and African national family planning programs have prioritized rural service provision. I don't think this is dissimilar from the situation with health service provision more generally. But the idea was that urban populations would tend to have greater access to private provision of family planning, and as a result could be expected to more or less get along with it. But in reality, almost one quarter of all African countries where we have sufficient data, unmet need for family planning is in fact higher in urban areas than in rural areas. Now that's so even if more sophisticated spatial and geographical analyses of distributions of unmet need actually show that there's considerable heterogeneity, there's considerable difference between levels of unmet need found in particular urban settlements and between particular areas of cities and towns. So let's take a look at the example of Kenya. Levels of unmet need for family planning in Nairobi, the capital, are quite considerably below the national average, but that only tells you a certain part of the story, because if we look then at slum areas of Nairobi, unmet need is in fact double the average for the city as a whole, and indeed higher than the rural level, the average rural level of unmet need in Kenya. There's also been some interesting work that has been made possible by the two urban health and demographic surveillance sites located in Nairobi, which are operated in part or in whole by the African Population and Research Center. And this work shows that actually some of the specific factors that influence fertility behaviors and the use of family planning can differ significantly between individual slum settlements. Okay, so despite the fact that these are two, perhaps to the kind of external observer, relatively similar kinds of settlements, when you start to look at the specific factors that are influencing the way in which people make fertility decisions and transfer ideas, there's something very different going on. So there's a real need from this perspective to try to get a more neighborhood level or a community level understanding of what those specific factors might be. That need for a more fine-grained socio-spatial understanding of some of those factors and those trends actually echoes a broader problem with this research more generally, which is that there is a significant research bias that focuses on large cities and that focuses on urban and rural comparisons. That's in part a result of the fact that demographic and health survey data simply gives us those urban and health comparisons. But aside from that, at the level of individual studies, there is this major bias towards larger, more established cities. We don't actually know all that much about rapidly emerging and changing intermediary cities or specific areas of spatial transformation like the peri-urban interface in larger or intermediate cities. So that's all I really wanted to say. I think we've gone a little bit over time, but we know a bit about these patterns and trends. We don't know exactly what is driving some of them. And ultimately, we do find a major challenge in the terms of the data which we can access about specific factors and trends. But I think Sue is going to elaborate a little bit more on that in her presentation. If you're interested in reading the paper, same shameless self-plug, but here's the reference. It's open access, and yeah, it includes Trudy as a co-author and Sue Parnell and some of our other wonderful colleagues from the scientific panel. So thank you very much.
Thank you, James, for the very good presentation. And this is an opportunity we want to give to Sue Parnell, who will be able to present the urban development experts, international urban development experts' insights into how family planning can work in their various sectors. So welcome.
Thank you.
Yes.
Thanks, everybody. This is the first post-COVID challenge. I'm not entirely sure how to use my specs back in the real life. So bear with me while I kind of work out whether I can see or not see. And James, you happily gave me the instructions on how to use this, so I hope I'm right. This is a piece of work which we kind of were able to add on in the project as it became apparent that the story which James has been highlighting was really fascinating. If you were interested in Africa, and if you were interested in the demographic trends, and if you're interested in the mechanisms of whether you can and can't get access to family planning. But we perhaps didn't know quite enough about how do you actually access urban decision makers. In other words, how do you make this knowledge make a difference? And so a small piece of work was commissioned to go and ask the experts, not to tell the experts, but to ask the experts about how it was that they could use information, and specifically how they could use information about family planning and reproductive health in an urban context. I happen to think that this piece of work has a slightly wider resonance than that, in the sense that I think it speaks to a lot of the debates which are happening in the urban community about translational research. In other words, how do you design information which will change, which is intended to change, okay? A very specific objective. And much of the work that we were engaged with in the project funding came with that objective. You heard Mary Ellen saying that. And that's quite a common element of work funded in the field of urban health generally. So it speaks to that. I also think it speaks to the question of co-production, which is very sexy kind of term, concept, method, if you like, used particularly within the more explicitly urban work, but where the logic is that by working, whether it's with a community or whether it's with the state, but with people who have knowledge, that they perhaps know things that we don't get only from the analysis of demographic trends or secondary or other kinds of sources, okay? So that we're co-producing knowledge together. And then finally, I think that some of what this work does is that it actually does speak to a community we don't often think about, who are the funders. And possibly to think about kind of how do you want to write a call for research funding in an area where you seek to make impact like that of family planning. Now, the family planning example is particularly interesting for us. I mean, because it's something we are all interested in, okay? It's fundamental to who we are. But I think it's also interesting for us as we think about urban health. And one of the reasons for that is that it's a difficult question. It's a really, really difficult question to talk about, partly because it's not an easy sell. Family planning and the link between family planning and cities is not quick. It doesn't happen instantly. So it's not instant gratification, basically. It takes place over time, over long periods of time, generally, and absolutely not in an election cycle. So you've really got to, it's quite difficult to make the case that this has got to be your priority and this is really important. You've got to actually get on with it. That's the first reason. The second reason is that family planning, unlike a hurricane or even frankly a pandemic, doesn't tend to happen in a crisis. And most often, governments and people respond best to a crisis. So it's much easier to change things if it's obvious that there's a massive problem. And because the family planning access question is a slow problem, not a fast problem, not a crisis problem, it's really difficult to get to, okay? And then of course, the sort of the bad press and the difficult issues and the cultural implications of some of the work around family planning, not least in the global south. We know that reproductive health generally has an extremely difficult historical legacy associated with eugenics, associated with racism, associated with colonial practice. Really important to acknowledge and to confront the politics of that, okay? And this is not just a question about the global south. We know also that even to talk about questions of family planning in the current moment in the richest country in the world is very difficult because of the discussion about abortion. Okay, and of course that's replicated in a number of other different kinds of places. And that's not to equate those, that's not what I'm doing, but it's to say that these are difficult questions to deal with. So if you're not interested in family planning, but you are interested in questions about how do you change cities, if you can do it for family planning, you could probably do it on a whole range of other things. And so it's one thing which really speaks in family planning and reproductive health's favor is that it is unambiguously a foundational question. And in fact, I put it to you that perhaps the real reason why we managed to shift the urban agenda was in fact because of the focus on demography. Okay, not in other words, we buried the family planning words and we elevated the demographic question, but that argument that we were moving to an increasingly populated globe, to an increasingly populated urban globe was central to the idea of the urban planet and was fundamental to the shift in the discourse about global sustainable development. So family planning and issues of reproductive health have been central to the urban question. And many people would argue, so would I, if I could turn the thing on, yeah, that it continues to be so. And James, I think the points you were making in your presentation just speak so loudly to that. Okay, this stuff is really, really fundamental and it's absolutely fascinating. But the argument that we make in this paper that James and I did for IASSP is that you need more than an intellectual case. You can't just say this is important. You actually also have to say not just why that it's important, but also how it can begin to be absorbed. And that is an act of research as much as it is an act of practice, okay? And it's an act of research because we don't know what we're doing, okay? It's not clear what the best ways were. And so we went to the experts to say to them, come, tell us, what do we have to do in order to make this interface work better? And the first thing they came up with, loud, clear, and you hear this in any number of other places, is that the data matters, okay? You need massive reform to the data. UN systems have begun to change, to begin to downscale, and to insist on a coherent urban definition. James, you're talking about the neighborhood scale and the importance of the neighborhood. There are lots of data experts in the room, but that interoperability, that interscalar character of data to be able to make the link between demographic data, infrastructure data, finance data, health outcomes data is absolutely fundamental. So that's the first key message. The second key message is really about strategy. Okay, and I've sort of alluded to this already, but it's to say that you actually have to have a strategy if you're going to land and overcome the political sensitivities about this topic. You've got to know something about who you're landing with it with and how they operate and where you're going to land it. Okay, that's a strategic question. It's a knowledge question. You need to understand who you are engaging with. You can't just say, I'm a public health specialist, listen to me. Okay, that's not good enough. You've got to say much more than that. Particularly because strategically, and this is the second point, you probably need to embed family planning and reproductive health questions in other issues. Okay, so if you take some of those photographs and trends that you're talking about, what's the link between 3.8 versus 4.2 as your figure that you're dealing with in terms of demographic change? That's huge when you start talking about the numbers of infrastructure development. What's the time frame that you're dealing with in terms of that? These are massive, massive questions. So being able to link those is really important. And certainly everybody we spoke to said, if you can make the infrastructural and the fiscal links, what does this mean for water provision? What does this mean for city budgets? What does this mean for taxation? Okay, if your demographic growth drops from 2.8 to 2.4, what does that mean over what kind of period of time? And we just haven't begun to do some of that work. And that's a strategic question about what do you prioritize and why and how. There's another point which is partly about strategy, but it's more about how you work. And what our experts told us was that it was really important to work collaboratively. What do they mean by that? They said, look, the problem with the urban debate, the urban space, the way cities are run, the way cities are managed, is they're not managed by one person. They're not managed by one department, okay? So if you're going to work on an issue that cuts across more than the rollout of a narrow service, which family planning and reproductive health does, okay? You've got to get transport to where the clinic is. It's got to be safe for people to get there. It's not just about whether or not you can get a condom, whether or not you're able to access guidance on women's health in various kinds of ways. So you have to work with various scales and actors. And for cities, it's not just local government and it's not just communities. You actually have to understand what national government does and sometimes what traditional authorities do. You need to be informed about how cities run. In other words, you need to know who to partner with. Otherwise, you're not going to land it. And similarly, you have to accept that the urban agenda is a very crowded space. Getting a seat at the table is not simple, okay? You got to compete with biodiversity, you got to compete with COVID, you got to compete with climate change, you got to compete with an energy crisis, you got to compete with war in some countries. It's really difficult, okay? And so finding the synergies between where the family planning stuff lands and the other issues that are on the table is really important. So in summary, what our experts were saying was try and co-locate your agenda if you can. Try and make friends with others who are seeking changes, which yours will come to. And then they said, you've got to be patient. Okay, I made that point at the beginning. The family planning thing doesn't come quickly. The wins aren't instant. Growth rates, are relatively slow to change. These are intergenerational changes quite often. The stuff is really quite slow. Also, it's very rare. I don't think in all of our fellows, correct me, if we don't have anybody who was able to say this individual changed everything in country X or country Y. By and large, it's an institution, it's a process, it's a set of ideas, okay? This isn't about one person. Leadership matters, but it's got to be embedded in institutions. And so, again, that takes some time and organization. Having said that, and we did these interviews before COVID, I think, James, we did it before COVID, the interviews, I've forgotten, during COVID. Maybe everyone was so concerned about that, but it's very clear that a crisis can create opportunities. So it creates a willingness to change. And so being opportunistic and looking out for where those entry points are is significant. You won't be surprised to hear that money counts. The change interventions that work well are not only funded, they're funded over time, they're committed to large-scale partnerships, and quite often they are part of a global network. And that's useful because it helps people to not be operating in isolation, particularly. Remember what I was saying about the cultural isolation and the cultural difficulties of landing this issue. Very difficult. You've got to learn to speak in a nuanced way in your particular context, but it's quite helpful to know that your context isn't the only one where it's very difficult perhaps to talk about things, and you can learn from others on what is there. And so the word back to funders is actually long-term interventions sustained over time tend to work better than short-term interventions. There's absolutely a message about capacity. Basically, the bottom line is we don't have enough. We don't have enough urban capacity. We don't have enough family planning capacity. And that's both in a research sense, but also in an operational sense. And so scaling that up and scaling it up across a series of domains, whether it's urban planning, so we get some focus on issues of family planning in urban planning courses, or whether it's some public health courses where we begin to learn to understand cities, are both important components of that. But the question of capacity, the good news is that there are going to be loads of jobs for people with this expertise. There's no problem with that. There's a massive demand at local government level, at national level, and across a range of places. And then finally, one of the big messages that I want to leave you with is this idea of being instrumental. Okay, so if you think about the project that we started off by talking about, it's a huge topic, okay? And the objective is to make a change and to make a difference, okay? And so the question is, how do you best do that? And And so what we asked experts what they would do. How do you haven't got enough funding here to run out a major new delivery program in 400 cities across the world, or 800 or 4,000 cities across the world. So what are you going to do? And one of the recommendations that they came up with was to be quite instrumental and to focus on data and to focus on the capacity to analyze data in ways that really make a difference at the urban scale, linking questions of family planning and reproductive health to issues which are fundamentally urban issues. Sometimes to do that in a local government context or in a CBO context, but organizations like the OECD, which have a gravitas beyond the individual case, perhaps to really push an agenda with them, with UN Habitat or with ICLEI, and a number of things. And then finally is the recommendation of making a community of practice. And so I would strongly encourage, before we go off for lunch, is just try and find one of the people in the room who you don't know. At least just meet them, find out what they do. You might want to pick up on email later. And just sort of know that there are other people interested in working on the field that you are in. Trudy, I can't see you. Are you down there? And I'm going to give back. Thank you. By the way, the answer is you don't wear your glasses.
Thank you, Sue, for that great insight. And I think we are moving well in the urban space and family planning and development. So I want to now welcome Trudy to make a discussion and share about more insights on the 8-country links between urban development and family planning. She is the co-chair of this particular project. I know we are able to get great insights. After that, we'll be able to have time for discussion and a question and answer. Welcome, Trudy.
Thanks, Eliphaz. Sue has told us about what the international urban experts think is needed to build this interface between family planning and urban development. And I'd like to tell you about our research that looked empirically at what extent is there this interface in 8 African countries. And like most aspects of this project, it was a wonderful team effort. And so really I'm presenting the results on behalf of a team which includes, but is not only, the people named at the top of this slide. And if you want to know more about this research, it's recently been published in the Journal of Urban Health, JUH, in June of this year. So the article by those people is there. And in that article, we say 2 things. We can't understand cities without understanding fertility, and we can't understand fertility without understanding cities. And if family planning's excluded from discussions about what it means to have an urban sustainability and health agenda, then that agenda can't be realized. The objectives were to look at researchers and policymakers' challenges in tackling multi-sector nature of urban health. So our lessons have implications for other urban health initiatives which require multi-sector or inter-sectoral action, and consider how to begin to link family planning and urban development in Sub-Saharan Africa. Over from 2019 to 21, we did stakeholder mapping, comparative policy document analysis, did around 100 key informant interviews across the family planning and the urban development sectors across 8 countries, which were Burkina Faso, Ghana, Kenya, Mali, Niger, Nigeria, Tanzania, and Uganda. So basically, the team was asking what links are there between family planning and urban development? Essentially what cross references are there between these 2 sectors, both by looking at policy analysis and by talking to key informants. The results, in essence, of the 8 countries, 2 countries, Malawi, and Ghana, the urban development sector included family planning in their policy analysis and development plans. We hypothesized this was because both of these countries have strong demographic research and they have strong national urban policies. In 5 of the 8 countries, the family planning sector explicitly included reference to urban development. That was not Uganda, Tanzania, or Burkina Faso. In the paper, we present a case study, and I should mention here, we were hoping in this plenary to give additional case studies as presented by Dr. Sunday Adedini from Nigeria. He would have presented case studies from Nigeria and Kenya, but unfortunately his visa was refused by Spain. It was an unjust discrimination, and I think we have to be conscious that this is happening increasingly to valued, esteemed, fine African academic colleagues. I've been in 2 conferences in Schengen countries in the last 4 months where several African colleagues have found the process just too off-putting and long, or they've actually been refused visas. I think we, whoever has voice among us, need to keep protesting against this, to be quite frank, racism. Anyway, we're in the Uganda case study, so unfortunately we're not going to hear about the Nigeria and Kenya case study, but our Uganda case study showed that essentially urbanization was perceived as automatically leading to a lower fertility. So urban respondents said, well, you know, the myth that James alluded to, that rural areas is a problem, but urban areas, we don't have a problem in terms of fertility rates. So this myth of associating urbanization as contraception essentially was still very much the case in Uganda. So urbanization was viewed as contraception. It very much ignored the heterogeneity that James spoke about, the intra-urban differentials that I'm sure we as urban health people are very familiar with. Basically, urban planners aimed at accommodating population growth, while family planning people aimed at containing population growth. There was this essential difference. And sectoral coordination was seen as, quote, an unimplemented mandate. Both urban development specialists and family planning specialists saw that there was a mechanism in the country, there was a mandate, a policy for multi-sectoral coordination, but it basically wasn't implemented. So in conclusion, intersectoral collaboration is challenging across professional and bureaucratic silos due to several things: a lack of cross-references in policies, that facilitation doesn't exist, a different understanding of the issues, a lack of budget or human resources to forge such linkages, and also a different, it may seem minor, but it's actually quite important that we found in our 8 countries that different review periods of work plans was a hindrance. So in other words, timing of reviewing of policies, which gave open doors to changes, that was out of sync between the 2 sectors. It's easier to make progress at a local level rather than a national level, especially if you've got strong decentralization policies in place. If Dr. Adedini had been here, you would have heard the differences between Nigeria and Kenya, Kenya being a very decentralized country where local forces come into play. You won't be surprised, there's a need for champions. Sue pointed that the experts have pointed to this, perhaps from donors or UN agencies to, in other words, sort of perceived as somehow outsiders rather than insiders, to achieve sustainability and a scale up of cross-sector successes. there's a need for internal consensus. And again, Sue essentially was saying this. We, if I say we here, meaning the family planning, people at demographics sector, we need to get our message straight first. What's the entry point that we want to use to urban development? And that will vary according to context, according to cities, according to the size of cities, intermediate cities, very neglected group of cities, particularly in Sub-Saharan Africa. And then once we've got our internal message straight, we need external advocacy and a concerted messaging and capitalize on this urban complexity. As we have said, the entry points might differ according to context. And these lessons are really relevant to any urban health issues that's culturally sensitive, needs behavioral social change, and has multiple determinants. For example, mental health. I've worked in urban health for decades. I'm retired now, but I used to, for example, in the 1980s, trying to get urban mental health onto the agenda in developing countries. And in a sense, the way that we would do that did that to some success was to say the same message. We focused on the fact that common mental disorders among urban women are twice as common in women than men. And we focused on that message. And actually in some countries, therefore, got urban mental health onto maternal health policies. So it was using that entry point. And doing this work with our team, the IUSSP team, makes me feel a similar thing. If we can internally get our message straight, we can then have effective external advocacy, if you want. I want to make sure we just have a few minutes for questions and comments, so I'll finish there. Thanks very much.
Thank you very much for the great presentation, Trudy. And we have the big concept in this panel discussion. We want to give room for a few questions or comments. We have less than 10 minutes so that we are able to conclude the session. So, yes. Yes, you can ask. Yeah, you introduce yourself and then you can bring the question.
Great, thank you. My name is Dr. Miran Tandu. I work for the University of Cambridge, but also collaborating with Sue on a couple of other projects with the WHO. Thank you very much for these presentations. I am not at all an expert in family planning, and even less more so in cities. So congratulations on this very groundbreaking work, I think. One thing that I've learned is about this fertility stalls. We actually had to look up the formal definition because it's not very easy to understand what it means, right? From a demographic perspective to stall. I just have a comment with two examples. Two things struck me, I think, from James' presentation saying, okay, we actually do not know what's happening in these settings. And then what Sue said about data and what Trudy was raising about, are we involving the right people? And also, are we looking at the data properly? In anthropology, we say there's a difference between big data and thick data. So my examples are from Mauritius, the island where I come from. There were two conversations around fertility decline, the first of which was the issue of brain drain. What we found actually in Mauritius, when we were asking, do we have everybody around the table? Who is it who's not here? And it turned out that most people that are leaving the cities are women, not only women, but actually women who are educated and women who are of reproductive age. And that is approximately even more than 60% of all brain drain. And that's a lot. The second example that I wanted to provide is related to who is not seen. So there's people who are not here and people who are not seen. In my country, abortion is still illegal. And some studies that we have done have indicated that there's a lot more people than we think terminating pregnancy. And we don't have that in the data sets. More importantly, I mean, it's topics that are very hard to talk about. So the issue of abortion has been on the table, and I was wondering if in any of those sites you have talked about hard issues like that. Thank you.
Thank you very much. We have a few minutes. I think you can give the mic to one of the presenters to do a quick response, or we can get a second question, then we can have joint response. Yes, she's here.
Thank you very much. Okay, so my name is Opeyemi Babajide, and I currently work with Alex Eze in Drexel. So I've heard through this name several times. And I think, I mean, I had this question in my mind, and then when Milan started talking, I felt that I think I should talk about this. I know Milan has spoken about the brain drain in the city, but I do know that Alex has recently spoken about raising the next generation of researchers in this field at the IUSSP meeting. And I saw Trudy's comment about how much that it's also good to hear him say that. All right, so I'm new in such a way that I've always done something on maternal and child health. And then I got this postdoc with Alex Eze, and I'm trying to look at intermediate cities. And, you know, listening to the presentations, I feel that there might be a gap. Now, I think that I had a lot of notes that I was jotting down because I felt like when Trudy was talking about the fact that we should get our conversations right and how to bring them into urban health, I stumbled because I followed her into the session, and I'm wondering how I never saw that, because it would have been good if I knew this was Olden, because this is my field, and I was drifted a little bit into a little bit of more urban programs rather, you know. So I'm wondering if there are, apart from smaller programs, smaller meetings and trying to meet like this, if there are actually active ways of bringing early career researchers into the field. I know Dr. Adedini as well, because I'm Nigerian, but I wouldn't say that we have that kind of collaborations being in the same community of practice, actively knowing what everybody's doing. Now that I'm interested in intermediate cities and how the maybe fertility pattern in intermediate cities actually drive the growth in urban cities, I would need as much collaborations as I would love to get. So that's me asking in terms of the fact that not brain drain in the city in terms of what Milan was saying, but I mean bringing bringing together like the link between folks that are already experts and then early career researchers in this field. I'm volunteering myself for the first person as the early career researchers.
Thank you very much. We could have, we're almost on time. You can give the mic to Trudy. You got some papers there. That was a newspaper article carried in Kenyan dailies, just trying to reach the policymakers. There was something on the desks. You can carry one. Thank you. So you can proceed.
Just to say, I've not actually thought about, I mean, it's absurd, but I've actually not thought about that question about brain drain, and it is absolutely fundamental. And probably relatedly, the question of remittances. I mean, and to just one could probably pick up on that. I mean, countries like Nepal, who have, you know, their biggest GDP contribution comes from remittances, which suggests missing people. So really, really interesting to think about, not just missing kinds of cities. But I think that that's part of the connection to what you're saying is that when ISSP started this project, Trudy had been working in this area for a long time. So I'm going to give her the last word on this stuff because she has a history of doing some of this stuff. But I don't think that there has been a community of practice, scholarly or any other kind. For the reasons that James was talking about, I think that family planning has been primarily a rural service delivery competency. The assumption that local government in urban areas would do it or that national was managing it, false, but there. And the scholars really dropped the ball. It'd be interesting to go into the kind of, you know, women's health literature to find out why they didn't get there. Part of it is that they've been city blind. But I don't think that is all of it. But that question of kind of how do you grow a community? I mean, look, we're not the biggest room filled of people. This tells you a story, right? And these are absolutely fundamental questions. So this project is winding down, but it's absolutely not the end. It should be the beginning, not the end. And to put your finger on exactly that stuff. And I think for me, some of it is about getting some big hard-hitting contributions in the field. And the problem is that some of the field is in the global south. Maybe we can harness the abortion debate as an entry point and a strategic entry point. I'd really like to comment, Trudy, about kind of finding those strategic entry points, and maybe I should just hand over to you.
Just a few reflections. It's 12 years since I've been to an international conference on urban health. So I was at the New York one 12 years ago. I'm retired, okay. So coming back, a big difference I see is the research translation focus among people. Call it what you will, getting research into policy and practice, research translation, different disciplines call it different things. But I think that will hopefully enable us to move closer to this community of practice, to a shared perspectives, to openness, to messages from the research world to the policy world. And in essence, to your question, you are the answer. People like you working in this way, being aware of this issue, particularly within Sub-Saharan Africa. And the answer is also the fellows that this project has produced, because they are mid-career researchers. Many of them said, we didn't even think about policy implications before, but now they've been trained up. They are the answer partly to this question. And so I am very optimistic, pessimistic about the numbers in this room, but you're all lovely. Thank you very much for coming. And a final word over to Mary Ellen. Thanks very much.
Yeah, I just wanted to mention, you mentioned you work with Alex Zezi. I don't know if any of you who are interested in these topics are members of IUSSP, but we not only have this project, but we have panels working on abortion research, on looking at reproductive health from a human rights lens, a wide variety of scientific panels working on issues that they're not necessarily always urban focused, but would be of interest to what some of you are working on. And I brought a few brochures if anybody's interested, and take a few. And we'd love more people to join because we're a fairly broad, multidisciplinary organization. So, and I will leave it at that. And I thank all Sue, James, Trudy, and Eliphas. And did I miss anybody, for a great session and representing IUSSP, and to our crew in the back. Thank you very much, in the audience.
Thank you so much. I think we could end it there. It's now time, but you're free to interact with us and get more from the same. Thank you very much. Thank you all.